This was about impossibilities. And I want to start by saying, I'm here because of impossibilities. I come from a history of lived experiences, including substance use, sexual abuse, and suicide more than once. And I'm here, and I had an incredible clinical and applied research career as a community psychologist, and I just retired and became emerita. But you know what? I'm still working, because I have the passion to do things like this question that seem impossible, but I'm going to show you a way that is possible if you have the passion to do this work. And I know there are people here in the School of Public Health. So when you think of the word empowering or empowerment, I'm going to show you how this journey has gone in helping women in this journey of this two syndemics of substance use and abuse and HIV, these last 40 years for me. So we have a problem still of substance use, actually globally. Alcohol is the worst substance of abuse in the world. And alcohol is prominent and easy to get, so that's usually the first drug. And the brain is still developing till age 25. And yet, there's lots of drinking, there's lots of drug use on this campus. You know, there's experimental, recreational, continued use, and obsessive use with ill regard to consequences. That's what we call addiction. So people go through phases and stop. Some people don't stop and their life changes and things happen. But women who are in substance use are also have come, when I've seen clinically, with other issues like I had, whether it was incest or sexual abuse or being, as we know, migrant women that have been brought into this country have been used as mules to bring in drug use and also end up in prison. I started a long time ago, I'm pretty ancient, in 1977 in the substance abuse arena. I ran a residential program, and then I came here 40 years ago, seems like a long time ago, to work with an outpatient treatment program, and I started focusing on injecting women who were injecting drug users. I'm trying to get better with my own language. We don't say AIDS anymore, we say HIV. We don't say injectors, we say people who inject. So I need to catch myself. But women, you know, there weren't programs for women, even in treatment, and women didn't go to treatment, just like I found that there weren't programs for women who had HIV. Men who had sex with men, there were programs. But for women who injected, there was a double jeopardy. They were injected mostly by their boyfriends, and then their boyfriends, there was a norm of sharing needles at that time, sharing works, and then they had unprotected sex with their boyfriends. Let me go back a slide and just show you that when CDC, and I'm glad to say that CDC's website is back up. We hope it'll stay that way. We started looking at the cases of what was going on with the injecting drug use and also heterosexual sex. Now, I was working, as I said, clinically, and we had our first HIV test in the 1980s, and this big man tested positive in our program. And he was very, very angry, and he threatened our staff and said, I had to walk him out and pretend like I wasn't fearful of him too. And he said, I'm going to infect every young woman I know. And he proceeded to do so because all we had in North Carolina was isolation and quarantine laws. And we started task force locally, and we started one for the state about what are we going to do about HIV. And for me, I really focused on this new epidemic of crack use, which was a cheap form of smokable cocaine. And it was, when we looked at the numbers, this is newer data, but when I tracked the numbers, and I worked a lot with the state statistics department of the North Carolina Department of Human Resources, it was close to 70% of HIV was found in women. So that was incident cases and prevalence cases over time. And I thought, what kind of intervention can we do that are with these that will help these women? And when I was working as a treatment director and a clinician, we did start women's groups. We did really train to do women-sensitive counseling, and we also went into the prisons. And many of the women in prison were there and also talked about their comorbidity. So women don't just start using drugs. They have a history of comorbidity. And so it's lots of things you have to address when you think of a treatment plan. So with this, I brought if you're really interested in the history of HIV in North Carolina or California or Boston or Uganda or Africa, I put together this book quite a few years ago, and it's really more stories about the history of substance use, some about the gay-related GRID, gay-related disease that was from San Francisco. And it really tells a story how we really didn't know what we were doing, and we really had to learn over time, because we'd say people are going to die in 2 years, then 5 years, then 10 years, and then we had antiretroviral treatment. But there's an intersectional issue of how we're going to help women if it's more about heterosexual transmission. And this paradigm is the paradigm I have used throughout all my studies, and I have been funded by CDC Robert Wood Johnson in the beginning, but I've been funded by the National Institutes of Health, which has been in the news a lot since 1994. And this is a paradigm. If you raise the awareness of a woman understanding more about awareness and education about what substance use does to them. The more you drink, the more you drug, the more you give away your power, you can't control yourself. And you change your attitude about your sexual health and learning about your body. Let me teach you some skills about sexual negotiation. Let me teach you how fast you can get a condom on and different kinds of condoms. Then you will see behavior change. Those are the hypotheses I had in my studies. And what happened? The Women's Co-op was born, and this is my logo. And this paper, this first clinical trial that was really important for African American women who used crack, 10% were living with HIV. It was published in the American Journal of Public Health, and CDC, that looks at all the studies that are published, found it best evidence. Now, being a best evidence really gave us the kind of reputation to be able to write more grants, and we did, for adolescent teens who were not in school, for women who were pregnant, and we also have an mHealth edition of the Women's Co-op, and we started working with men and couples, and you'll see that in just a moment. I did one career talk in 2001 in Washington, and I was asked, after talking about how, they sat me down and asked me, how do you do interventions? And I talked about mixed methods, the qualitative, the formative work before you do trials. And they said, we'd like you to go to South Africa. And I thought, what am I going to do in South Africa? But 1 in 4 women who were having babies in the hospital were testing positive, and they needed to do something. And we were just beginning to roll out antiretrovirals. And I was on the advisory board for that. And so you can see in South Africa, along the trucking routes, there was more HIV. And I went and I said, okay, I need to find women, because a supplement was attached to one of my big grants. And I went there. And I got my first ethics review so that I could start asking questions. And the biggest social determinant, as we know social determinants impact health, was poverty. And also cultural differences, because boys were favored to finish school and girls came in from the rural areas to work. What kind of work? They conducted sex work, because as one young woman said, when I was 8 years old, my mother said, my body was my bank account. I will never forget that. And I heard it in other places. So you can see here, even though South Africa is a very large and high economy, even though it's out of apartheid, many of the communities I've worked in look like this. So we ask questions like, what are your walls made of? What is your ceiling made of? Do you have running water? So you begin to really gauge a sense of poverty. And you can see the shacks. So asking those questions is important. However, asking women why they use drugs and why they are conducting sex work is because it gives them the edge to talk to men. And they can think better. It gives them confidence. But after a while, they're just doing drugs so much, they're not using any protection. And some of them were saying, I use 2 or 3 condoms at a time, but that's not effective because they come off. So they did not know you get the air out and how to use condoms properly. So it's beginning to form, how am I going to think about adapting an intervention in the US? You just can't parachute it in. You really have to work with the community that you're working with. Here, I had a sabbatical in India. On the trucking routes in India, they're very small. Here are women working in those townships you saw, that we call them under-resourced communities now, under that lean-to, and men come in for quickie sex. And I caught a picture in a car of this little girl, because girls are so, thrown away. You hear about babies delivered in the hospital that are girls and are found in bushes afterwards. So we are really dealing with these patriarchal countries and cultures that don't value girls. So, as I said, when you take an intervention that you know it has core elements that are good, that are going to work, but you can't drop it into another culture, you have to talk to the people you want to reach, so the young women, and talk to the healthcare providers you need to get referrals to. So here, but if you feed them, if you bring the food, they will come. So that's always been my thing. We feed them. There's a woman with a child. And talk with women about where they can be found with this work and how we should do the adaptations, which we did in all the languages in South Africa. I do want to say there, when they say we're working in the bush is the high grasses. And the government got very involved with us and offered stipends for all of these young women that were going to work alongside of us, because they hadn't finished school, but they got credentials from us and pictures, certificates. They were so happy. And they would let us know where the gangs are fighting, because there are a lot of different gangs going on in South Africa, and they tend to shoot. Even the health departments had to put up concrete walls. And then they would say, stay out of this community, go to this community. So we were working in consort with these community women, and they were part of us. So the Young Women's Health Co-op was born, and the Women's Health Co-op was born. So we had several iterations of the studies. And as you know, in African countries, there's lots of different language or dialects of languages. And there's 22 there, but there's 11 formal. And we did a lot of translations to make our ethics people happy, but they always liked English because that was taught in school. But at least I made our ethics people happy. And there was also a personalized plan for each woman to say, besides being an individual and in groups, what is it you want for yourself? When we talk about giving you skills, what do you want? And what they really loved, I want to say individually, is learning how to use the female condom, but also learning about the male genitalia. So they all got a penis. And they learned about what is it about men's erection? How, can they keep it while I try to get a condom on them? And that was very fun. They laughed. They didn't know what was the part about men that they really liked, and that was the ways of having sexy, safe sex. And knowing if they drug and drink, they can't do all these things, and also get condoms on quickly. So when you do these kind of studies, you also have to publish them if you're funded by NIH, which we've done. But this is just a slide to show you about the important questions that you're looking at. Do you reduce your alcohol and drug use? Or do you increase your condom use? Do you also learn how to do sexually negotiate with your partner, and especially your main partner? Because one of the things about increased HIV in South Africa is from a long tradition of many wives, because wives died in childbirth and so on, is multiple partners. And the men, when I had focus groups with men, would say, well, that's what we do. We have lots of other partners. And you'll see in a second what we do in the men's group. But you can see we'd had really great outcomes. But what do you do with the outcomes with the community that are part of this? You communicate with your community advisory board regularly. And you also give a brief at the end. And they become your partners, and they also write letters for you to do the next work that you never get done the first time. So this is just a mash of our briefs and our newsletters. Issa's here, she's been a part of this. Now she's in graduate school. We have had interns and students work on all these projects from UNC. This is to show you how we've advanced each time. So you saw a little bit of that social ecological model earlier. This is just one to show over time we got ART, antiretroviral treatment. Then we got PrEP, prevention for someone who is negative when they test. But we also started dealing with stigma in clinics, because some providers would say, I'm not going to give that girl any birth control. I'm not going to give her any PrEP. She shouldn't be having sex. but they are having sex, and they're having unintended pregnancies. So we had to adapt an intervention for the providers, and we're presenting that. I'm going back next week, even though I said I'm retired, right? And we're presenting that, and now we're working in the community. So we have also worked with men, and so you can see many studies over time. And the one that was most important to me after many efficacy trials is this implementation science trial, because after you do a step wedge and an implementation science study, you can then say to the government, who's always been involved with what we do, because we have to get ethics from the government too, is will you take this into your usual practice? And I can say, because my tradition, my actual training is in clinical addiction, is that the substance abuse treatment programs in Cape Town, South Africa, has been using the Women's Health Co-op for the last 5 years. And when I go next week, part of my job is not just the brief on the adolescent project in one part of South Africa, is that they've asked for booster training. And of course, more of those penis and vagina models. So that is, for me, one of those things in your career that feels good, has hope, seems impossible. So I'm going to leave you just with the end here and talking about, in working with men in a patriarchal society, the men say, we know when we drink, we rape. We know, well, my father disciplined my mother, my grandfather disciplined my grandmother. Discipline meant beating. They said they're okay, but we know it's wrong. It's against the law. They'd say, who changed those laws? So working with men, especially men in gangs, was a real learning for me in thinking how we were going to develop the men's intervention and a couples intervention. Now we're on a second study with couples, with PrEP and ART. So there is progress, but sometimes progress is slow. And it's hard. And you have COVID, and you have lots of things that happen in the real world when you're working. So what I want to say for the last slide that I tell you, for all of us, at whatever age, because I know I have 2 grandsons in college, is that we are global citizens, all of us. This may not be your passion, but when work we do to make a difference, find your passion. We are change makers, and help heal this world, because it's so chaotic. And like that little girl that I was doing some babysitting for, that was just a sweet moment. She needs you, they need you. Be the impact. I have more of these buttons if you want them at break, but I thank you very much.